Perfect. So today we're going to start off with the title of the project. So the efficacy of laser therapy in patients with knee osteoarthritis. Basically, we're going to be talking about how valuable laser therapy is as a treatment modality for patients with knee OA. So, all right, this is for the site of physical fitness. Again, I just want to thank you guys for letting me an opportunity to be here. My name is Dante or Damien Anoa. And today's date is the 23rd of November. So the goal of the project, again, is to just talk about how, basically how good it is as a treatment modality compared to the other non-pharmacological treatment modalities. And I chose this project because upon entering physical fitness, I found out about laser therapy and I had an interest in it. Knee osteoarthritis, because I had some issues with my knee in the beginning and I wanted to see how laser would perform against it. So we're gonna start. So we're basically gonna be starting with the overview of what osteoarthritis and what it is pertaining to the knee. So OA, osteoarthritis, is a degenerative joint disease characterized by progressive loss of articular cartilage and reflected clinically by pain, restricted range of motion, and muscle weakness. Now, the muscle weakness is going to be due to inability to properly use the knee due to the pain. And we're going to talk about it later on in the slides, but the muscles primarily affected are the quadriceps, your gastrocs, and just pretty much the whole lower limb. So again, osteoarthritis is the most common joint disease in adults around the world, with knee OA, knee osteoarthritis, being the most prevalent. So etiology, so this is what are the causes. So it's either classified as idiopathic or secondary. Idiopathic meaning there's no known cause, it's kind of spontaneous. And secondary meaning that it could come about from a pre-existing underlying condition. Some examples are post-trauma, congenital, malformation, malposition, varus or valgus. That's just biomechanical discrepancies if you're like caved in or extended out like so. Post-op, metabolic disorders, for example, diabetes and endocrine disorders. It's believed to be both mechanical and molecular events in the affected joint with gradual onset and usually beginning after the age of 40. Now, among the various joint structures making up the knee joint, the hyaline joint cartilage, which I'm going to skip right now so I can show you what that is, which is just this cartilage that covers the end of the bones within a joint, just there pretty much to provide extra cushioning, that starts to deteriorate. Now, that's where the start of knee OA, that's how it starts to happen because of the deterioration. So the pathophysiology, so what is actually occurring on within that joint. So there's a dynamic equilibrium between the continual ongoing formation and breakdown of the cartilaginous matrix, which is regulated by the interplay of anabolic influences. And for example, we have IGF, insulin growth factors, catabolic influences, interleukin, tumor necrosis, and proteineases. So these are just like pretty much what's going on in between the synovial joints that's keeping it from the breakdown and the formation is just keeping that working as in a unit. To a limited extent, these mechanisms can eliminate or compensate for the harmful influences that cause osteoarthritis by stimulating and modifying the metabolic activity of chondrocytes, which is what's going to make this cushioning, or what's going to make this cartilaginous reinforcement around the bone. When these harmful influences exceed the system's ability to compensate, however, the matrix degradation occurs. So when the breakdown is greater than the formation, that's when he's going to start to deteriorate and lead to knee OA. So here's just a list of other therapeutic interventions that can be used to treat knee osteoarthritis. We have the most commonly used, which are NSAIDs, so non-steroidal anti-inflammatory drugs, basically just to reduce the inflammation and ease the pain. That's what's prescribed to most individuals with knee OA, but what's preferred is not the medication, but rather patient education, weight reduction, because most of people with knee OA are obese, electrical stimulation, manual therapy, strength and exercise, ultrasound, orthotic devices, and what we're going to be talking about, low-level laser therapy. So, a little bit about laser therapy. It's light amplification by stimulated emission of radiation. So we all learned this in the beginning when we learned about laser therapy. It works through a process called photobiomodulation. When the laser is turned on, it produces a beam that is near an infrared frequency. When it is absorbed into the body cells, a cascade of events occur, resulting in an increased production of cellular energy. With this increased energy, the body is able to better handle inflammation and increase the clearance of damaged cells. Summary: the laser is absorbed by the cell, producing a boost of energy that increases circulation, reduces inflammation, and improves healing. So I just included this picture to show what our class laser, which is a class 4 laser, compared to the standard laser that is pretty much used everywhere else. So class 3, as you can see, the window of how, the target, which is going to be like the deep tissue, it doesn't really get far into the body. With a class 4 like ours, and with a class 3, you have to be on the surface of the skin at all times to actually have an effect. With a class 4, we modify the intensity, but if we were on a 10 and somebody couldn't handle it, we could be off the skin and still have the same effect. So this is a break I put here in case anybody had any questions so far. No?
Makes sense so far.
Great.
Raise your hand if you have knee issues. Oh, just me? Okay, never mind.
All right, can I?
No, I've got osteoarthritis in my knees.
So we reviewed 2 studies as far as pertaining to laser therapy and knee OA, and based off the 2 studies, the effective low-level laser in the combination with an exercise program in patients with knee osteoarthritis was assessed in these studies. One of the studies named by Michael and colleagues states that the positive results were found in low-level laser therapy when associated with exercise in yielding pain relief, improvement in function and activity compared to the placebo groups. It is assumed that the analgesia, which is the inability to feel pain, in the laser group after laser therapy may have been a consequence of the anti-inflammatory properties of the low-level laser at 3 joules. Now, before I continue, I'm going to be saying joules a lot. I just want to make sure that everybody knows that joules, as far as our laser, is just what you see down here is just the watt times the time. So I don't know if we haven't noticed that already, but the difference between the 6 joule treatment and the 3 joules is just that they have a higher intensity of the wattage. So they noticed improvements with the 3 joules applied to the specific points, which I'll get into later, of the knee, suggested by the recommendation of the World Association of Laser Therapy for Osteoarthritis. Keisha and colleagues carried out a clinical trial according to the recommendation of Walt, using a higher intensity, 830 nanometers lasers on an average power of 50 and 100 megawatts respectively, with a dose of 6 joules. So basically they just use a higher intensity, and they both have positive results in improvements in the global health status of the knee osteoarthritis patients. So now we're going to get into the optimal intensity that we found, and with our laser, we have standard presets on 810 nanometers and 980. So I should have brought the laser in here. But if we had the laser in here, the laser on a preset 10 watt protocol would have more of the 810 nanometers compared to the 980. The only difference is between them is that the 980 is just the wavelength. So with the 810, it's not going to go as deep, but with the 980, it's going to go deeper. So wavelength is the main determinant of the laser's depth of penetration into the tissue. Hemoglobin and melanin absorb photons at low at lower wavelengths, and water absorbs at those of higher wavelengths. So the optical window around 790 to 980, which is just like our class for laser, where the laser photons are least absorbed by these other three components and therefore penetrate the deepest. These deep penetrating infrared lasers are ideal for pain management therapy, and optimal frequency was 3 times a week for 3 weeks before they started to notice positive results. So now we're going to talk about the primary sites of focus when dealing with laser therapy. So on the knee joint, I will pull up my knee to show a good example. We're going to be focusing on the points right around the kneecap. Now, common areas treated follow a similar trend. Laser treatment is focused on the synovial region of the knee. The selected 8 points are the medial and lateral epicondyles, which are right here on the femur. The lateral and medial epicondyles of the femur and tibia. So right here of the femur, right here of the tibia. Medial and lateral knee joint gap, which is right off the edge of the patella on the knee joint, and the medial edge tendon of the biceps femoris and the semitendinous muscles, which are your hamstrings. So right in this popliteal fossa in the back. They focused on the treatment area being basically just around the kneecap and on the popliteal fossa. So now in conclusion, there is strong evidence that exercise reduces pain and improves function in patients with knee osteoarthritis. And this may explain the maintained benefits even after laser therapy was discontinued. These findings suggest that that analgesia, which is the inability to feel pain induced by low-level laser therapy, resulted in improved exercise performance. And this combination with the laser therapy resulted in prolonged analgesic effects. It is also demonstrated that with the laser, functional improvements in the laser group, there was functional improvements in the laser group compared to the placebo group. So I just want to, so we got the references, but further note, laser therapy alone is not a viable treating modality for knee osteoarthritis. It has to be in combination with exercise because due to the pain and the limited range of motion, muscles are going to atrophy. And with the laser, although it's going to stimulate that response to get the cells back in, proper rhythm, without without strengthening the muscle, you're not going to be able to actually use your leg like how you used to. So,
Do you have any recommendations or contraindications as far as which exercises for the leg?
No, but we would focus on strengthening the quad, the muscles that were weakened. So the quad, gastrocs, pretty much those would be the main areas of focus, but we'd focus on strengthening the whole lower limb. But those would be the 2 main muscle groups. So now, is there any questions?
No, we're all good.
All right, that's perfect.
Nice.
Hello, everybody. Welcome again. My name is Damian Anoa, and I'm just going to be talking again about the my project, the efficacy of laser therapy in patients with knee osteoarthritis. And this is just going to be a little reflection video. And overall, I think the project went by pretty well. A lot of material was learned. Although I didn't get to actually run the experiment on a willing client, in the future, for future studies, I wish to actually get the chance to practice on the client. Unfortunately, there were no available clients in our facility with knee osteoarthritis that would let me practice on them. This could be due to COVID and other external factors, but regardless of that, the project went by pretty soundly. There was back-end evidence that proved that knee osteoarthritis can be helped with laser therapy. And what would I do differently? Again, that would be actually running the protocol on willing clients and testing to see if within the 2 to 4 week period, which is the treatment period, if their symptoms would be alleviated with the treatment or with the laser therapy. Thank you.